Hi, everybody. Welcome to the IU Bioethics Grand Rounds. This is hosted by the IU Center for Bioethics. I'm Peter Schwartz. I direct the center, and I'm thrilled to have our speaker here today, Colin Halverson, Assistant Professor of Medicine and faculty investigator at the Center for Bioethics, will introduce her. But I just wanted to say a word here about our series, which, as most of you know, is monthly or bi-monthly. It is experts from on campus and across the country, when we're so lucky to have them, on issues in medicine and society, especially bioethics and related areas. Our next bioethics grand rounds will be Amber Comer, an IU professor who also runs ethics issues and activities at the American Medical Association, speaking at our Silvers lecture on Holocaust, genocide, and contemporary bioethics. She'll be speaking about Nazi atrocities and the birth of modern bioethics. And then in May, we are hoping to have, although there's a little bit of uncertainty for a couple of reasons, Paul Han from the National Cancer Institute on medical uncertainty in medicine, and especially bioethics issues there. So our talks are all streamed live for people online, and available live, and they are recorded, and they're on our website at bioethics.iu.edu for all of eternity until the end of the internet, which who knows when that is. And without further silliness and ado, I present to you Dr. Halverson to introduce our speaker.
Hi, everyone. I've promised to keep this quick. It is my great pleasure to welcome my colleague and friend, Meghan Halley from Stanford University. She's assistant professor in the Center for Bioethics there. And she, like I, is an anthropologist by training. This is actually how we met several years ago because she kind of blazed the trail for me in pursuing K01 from the National Human Genome Research Institute, and she also is a recent recipient of an R01, I think an R01, also from NHGRI. So without further ado, welcome. Thank you for being here.
Thank you, Colin, and thank you for inviting me. As originally a Midwesterner myself, I always love to come back to the Midwest. California still feels like a foreign country, no matter how long I live there. So today I'm going to talk about how we think about value, and particularly how we think about whose values underlie the way we think about value of all these exciting, but also very complicated new genomic technologies, specifically in the context of rare disease. And I'm going to, it worked last time. Nick, what am I doing wrong? All right, I'll just click it, maybe. Okay. I have no financial conflicts of interest. I have a few different affiliations that are all exciting and fun, but not super relevant. So I'm going to move on. So today I want to talk about three big topics. I'm going to start out by talking specifically about diagnosis and the use of genomic sequencing, including exome and genome sequencing for diagnosis of rare genetic diseases. And then we're going to talk a little bit about gene therapy to treat some of these rare diseases. I'm sure you've seen some about this in the news. And then I want to end by talking a little bit about the role of patient advocacy in the rare disease space, in so much as the way that advocacy functions is related to how we think about the value of these new technologies. So I suspect many of you have seen this graph. It's been around for quite a while, and it's demonstrating the cost for DNA sequencing and this incredibly rapid drop of that cost over the last, let's see, when does this go back to? Last 25 years now, but really since about 2009, when next generation sequencing really came on board. This exciting new technology is really changing the landscape of medicine in many really interesting and complicated ways. One way that I would argue it's changing medicine is in creating a new category of patient. If you look at the, let's see, on your left, that is the number of PubMed citations that use the term undiagnosed, from 1974 all the way up to 2002. And the one on the right is Google searches for the term undiagnosed, which also, as you can see, are increasing dramatically. And actually, I should update this figure because in just the last 2 years, you see an even more dramatic increase. But what does that actually mean, that this term undiagnosed? We could say, anyone in the Undiagnosed Diseases Network. Many of these patients have one or more clinical diagnoses. We know what is happening, but we don't have an etiologic diagnosis. We don't really know the why. So here you can think of patients with idiopathic epilepsy or intellectual disability. Are those patients undiagnosed? Perhaps in the past they wouldn't be considered that, but these days we're using sequencing to try to understand not just the what, but also the why. But what about patients with autism? Do we really think about them as undiagnosed? Yet we're using sequencing in a very similar way to understand etiology, but not necessarily the what, the clinical phenotype. And you can, I skipped one, and you can think about something like biliary atresia. If you're not familiar with biliary atresia, we don't know the cause of biliary atresia, and we don't think about those patients as undiagnosed, in part because sequencing doesn't appear to be a very useful tool. So the tool is in some ways defining the category of the patient. And then we have very interesting ways in which sequencing is actually splitting patient communities into diagnosed and undiagnosed, and what was previously a single group. And there's some really interesting work that's been done in porphyria, where patients who have a diagnosis of porphyria but don't have a genetic diagnosis are expressing the feeling that their diagnosis was in some ways taken away because they don't have the full picture. They only have the what, but not necessarily the why. Similarly, Charcot-Marie-Tooth, we found, I think now over 80, I know some geneticists in the room, so many genes for Charcot-Marie-Tooth. It's unclear whether this is actually one disease or actually many different diseases. And we're seeing the same thing with cerebral palsy. So it's really this category that has many different meanings depending on the context that you're thinking about it. At the same time, its use has spread significantly, and since as of 2014, we still saw about 50% of patients who got all of this clinical testing still didn't find this etiologic diagnosis, if you will, regardless of phenotype. But these were patients showing up in medical genetics clinics. And so given the ability of these technologies to really query the genome and the higher diagnostic yield, you can see there, this is from a paper, I don't have my citation on there, I apologize. From a paper that's back about 5 years ago now, the diagnostic utility, the ability of these new technologies to identify more diagnoses has led some of the professional societies to actually recommend this as a first-line test for patients. At the same time, though, we've seen coverage for sequencing lag far behind patient interest in many ways. So this is, again, a little bit outdated, but I think it actually better reflects kind of where we're at with genome sequencing as opposed to exome sequencing. But in 2021, just over half of patients had access to sequencing as a covered benefit, with significant differences between public and private payers. And payers really are making the argument that there are no therapies for these rare diseases. It's unlikely to change clinical management or outcomes, because for payers, they define value in a very narrow way. They think about it as essentially QALYs, quality adjusted life years, and whether you get more QALYs or more health for equal or less cost. And if you have a diagnostic technology that provides no actual clinical benefit or change in patient outcomes, they're quite reticent to pay for it. So in part because of this issue of challenges in access to coverage, a number of studies have actually proposed models for expanded models of value, including this idea of perceived utility. So this is a model from Hadley Stevens-Smith and her colleagues from 2022. It includes this long list of components that make up this concept of perceived utility. Includes clinical benefit. So in this case, they're talking about informing clinical management, not improving health necessarily. They're talking about kind of cognitive benefits. So just this idea that there's this intrinsic value of knowing what the diagnosis is. And they're talking about behavioral benefits, so thinking about reproductive decision-making, for example, in families, as well as kind of emotional benefits. So whether that's, relief of guilt for parents who felt like perhaps they did something while the mother was pregnant, to to cause a condition. And so the argument that is being made is that, yes, we know there's not health outcomes changes in when patients get diagnosed with these rare diseases, but it doesn't mean they don't have value. They have a wide range, they're arguing this wide range of different types of value. This concept was actually the product of the increase in the use of genomics. And it actually didn't even exist in the literature 20 years ago. And I imagine you can think about many different types of medical interventions that have some different type of perceived utility, right? Patients can see value in healthcare interventions for all sorts of different reasons. But in part, to make this argument that this should be a covered benefit, they've created this additional category to emphasize this broader idea of value. But the literature has a few problems. First of all, most of it is cross-sectional. There's almost entirely a lack of control groups. So they're not looking at whether, for example, patients who get other interventions are having perceived utility from those interventions compared to diagnosis. There's also this real focus on proximal outcomes. It's very difficult to get long-term outcomes from these patients because partly our fragmented healthcare system and partly, you're talking about a very diverse set of patients, not necessarily patients with one specific disease where there may be, a clinic that they all funnel through. We also don't know whether perceived utility is something that kind of everyone experiences or whether there's actually factors that predict whether a family or patient or family may see a test or a diagnosis as valuable. We don't know whether there's variation by diagnosis or type of diagnosis. And we also don't know what impact really these technologies are having on patients who get them and don't get a diagnosis, which is still quite a significant percentage depending on the study. And so I'm going to talk about some data from a couple of different studies that we've conducted over the last few years. Some of this is from my KO1 that Colin mentioned, and another is from actually a pilot study that was leading up to that work. So we did a pilot study that was intentionally oversampling for diversity in terms of race and ethnicity. And we did these single in-depth interviews with parents of children enrolled in the Undiagnosed Diseases Network to try to understand how they perceive the value of sequencing, either exome or genome sequencing. And then that study informed what we call the ValueSeek study, which again was parents of undiagnosed children, but we really did purposive sampling for variation. So we weren't just looking at race and ethnicity, but also trying to understand variation by level of education, rurality, et cetera. We use multiple data collection methods, so I'm going to primarily talk about the qualitative data today, and we followed them prospectively. So we actually enrolled them after they'd had sequencing ordered in either a clinical context or in research, but before they had gotten results back. So we enrolled them at baseline, and then when they got their results, we followed up with them again right within that kind of week window of when results have been returned, and then we came back to them at least 6 months later to ask them not only about kind of their background and their journey up to the point of receiving sequencing, but also what they thought about the diagnosis, what happened immediately after, if anything, and whether they perceived some of these different benefits that had been proposed in the literature. And so this is a conceptual model that we kind of came up with, and I'm going to kind of walk through this, and I hope you can, okay, it's a very large screen. You can probably read it. But so first of all, we were thinking about what are the baseline characteristics? What are the characteristics of patients and families going into sequencing that might shift what they ultimately see as the value of sequencing? And then for those who are diagnosed, what are the mediating factors about what is it about the diagnosis or the process of sequencing that might shape perceived utility? And then what's at the end of the line for undiagnosed families? I'm sorry. So here you can see we have a really long list of factors that came out of these baseline interviews, families talking about what was really shaping, in particular, their expectations, but also as we followed them over time, we saw also their outcomes. And I'm not going to go through all of these, but I'm going to give you a few examples. So we found that the medical stability of the child, particularly at the time when the results came in, not necessarily at the time when the tests were ordered, was pretty critical in helping them think in shaping the way that they saw the value of receiving a diagnosis. Or of not receiving a diagnosis. So if the child was medically unstable, not getting a diagnosis was perceived as a really negative event. Whereas if the child had stabilized since the point of testing, or if they had kind of always had a medically stable phenotype, but again, like a child with IDD, intellectual developmental disability, but otherwise medically healthy, they describe this as actually a really positive thing, allowing them to really let go of this question. At the same time, they talked about really this process over time. And again, in the past, they really felt this strong need. But right now, because the patient's so stable, the urgency really changes. We also see parents talk about really their own personal perceptions of uncertainty and the extent to which they felt comfortable living with not knowing the answer to the reason behind their child's condition. And this parent's talking about, no matter what the diagnosis is, even if it's a terminal diagnosis, she's anticipating relief because there's just so much uncertainty right now. And of course, these factors intersected, right? So this parent, her daughter was also very medically unstable. And so it was a combination of the child being unstable and also that uncertainty that came from that instability that really, for the mother, inflated this expected value that they thought would come out of diagnosis. Oh, I'm sorry, that's my repeated quote. And then they also talked about access to services and the services that they had, whether they were able to access the services that they felt their child needed. So this mother talks about, because of the phenotype of her child, he wasn't able to access any of the, for example, in California, they're called the regional center services, they're county services that provide a lot of special needs equipment, like car seats, as she's talked about, chairs, et cetera. And he had not access to none of that because of the way the eligibility criteria are structured, at least in California, he didn't fall in that, in any of those buckets, as she says, because he didn't have, not only did he not have a why, but he also really didn't have a what. On the other hand, when you see children with different phenotypes, they come into sequencing having access to a lot of those different services because they have this phenotype that actually allows them to get services in the first place. And so there's really this intersection between access, the what of the child's condition, and making the why variably important. And then what I want to talk about a little bit now is actually socioeconomic status. So this actually came out of doing a comparative analysis of the patients in our study who were, we have in the Bay Area in California, the largest immigrant population group is Hispanic patients or immigrants from Mexico and Central and South America. And we had a subset in our study. We did interviews in Spanish with parents of children who had undiagnosed conditions that really had limited English proficiency. And we wanted to look at how those families talked about the value of testing and diagnosis compared to families with essentially higher socioeconomic status and better access to care. And here's a mother who identified as white and English speaking, and she says she feels like the biggest challenge she was having was this relationship with her child's physician, but that that when they got this diagnosis, the physician really changed how he talked with this mother, and it really improved their relationship. And she says he no longer saw her as that worried first-time mom. But when we looked at some of our other participants, this is a mother who says, I think even the doctors here, they just keep calling it was multiple sclerosis was the term that she used, or other general term for a neurodegenerative disorder. Sometimes they do refer to this certain gene mutation, but it's rare that they even bring it up. So while this first mother was describing essentially using this information and essentially using it to change her relationship with her provider, this other mother is talking about how it really changed very little about her child's care. We also looked at this idea of kind of social utility, or this, one of the arguments that's made as part of the perceived utility literature is that, this diagnosis allows families to connect with other families like themselves. And here a mother is saying, this was one of the biggest plus items, was finding a group of other families with the same gene to better understand where they're at. But on the flip side, here's a mother who's saying, I don't want to be sent a list of people who have the same illness as my son because I don't want to look at advanced cases and I don't want to watch how my child will die. Now, I will say that this particular reason for not wanting access to these social connections was a bit unique. The more common reason that the Spanish-speaking patients talked about was language and access to those types of groups, which were predominantly English-speaking. But I think it speaks to this sentiment that just because this could be a potential benefit of diagnosis, it doesn't mean that it's something that's of value to all patients. And I think probably the most striking example comes from the comparison here. So this is a father who says, I went ahead and formed a foundation. We're going to come back to this at the end of the talk today. And they're getting it off the ground, and hopefully they've gotten a small group of researchers together that hopefully will help them decide on a research agenda and develop treatments. And as you can imagine, our Spanish-speaking families had a very different experience. In particular, this mother talks about how her son doesn't even have papers. He was undocumented, or insurance, so they can't do any follow-up testing. They could get him a diagnosis, but they can't get him any of the care or support services or anything else that comes from this diagnosis. And so, part of what I think about when I think about this particular case is, if you're familiar with this space, there's been so much emphasis on diversifying rare disease databases, genomic databases, particularly in terms of ancestry, which is not the same as, but correlates with in some ways, race and ethnicity, as well as socioeconomic status because of racialized medicine in our country. There's been this focus on diversifying databases and very little discussion about whether the benefits we're saying essentially they're making this argument that we need to diversify databases so that all populations can benefit. But there's no discussion about how that benefit is actually going to get back to these patients who already experience such significant health disparities. So also looking at this variation, we started to wonder, the personal utility literature, we don't hear any of these second perspectives. We're really hearing primarily about how they are connecting with other families, and they really are appreciating these various types of personal utility. And so we did a systematic review to look at who was in the studies, what their sociodemographic characteristics were in all the personal utility literature. And so you can probably guess what we found. And I will say, just starting out, my first reaction to this was like, oh, it's not actually as bad as I thought it was going to be. So, sure, only a third of the US population has a bachelor's degree, and only 60% of the population identifies as non-Hispanic white, but it could be worse, right? But then, when we removed the two studies that focus specifically on racial and ethnic minority groups, the mean proportion of white participants increased to over 80%, so just removing two of the studies. We also noted that there were only 274 Black participants across all quantitative studies of personal utility, compared to almost 8,000 white participants, and nearly half of the Black participants in all of the qualitative studies came from a single study, specifically focused on the perspectives of Black patients. And one other thing we noticed is that the study on Black patients' perspectives was titled as such. I think it said African-American patients on perspectives on personal utility of genomic information. But none of the other papers that we reviewed that were 90 or 100% white participants were labeled white patients' perspectives on, which I think highlights the way in which we as researchers can inadvertently reinforce the notion that the white perspective is the norm, but from which other perspectives deviate. So going back to our model, we also were interested in, once they got that diagnosis, so now following participants into that return of results phase, what were the factors that really shaped what they ultimately did perceive to be the benefits of sequencing? And what we learned is that there were so many contingencies that really were related to the diagnosis itself. So we have one parent whose child received a diagnosis of an ultra-rare disease, which if you get to the point of sequencing, it often is ultra rare if it's not being able to be picked up on panels or something like that. And she's really frustrated with the lack of information the disease brings. Have another slide here, no. This parent talks about another factor that's related to prevalence and as well as to community. So she's talking about, October is Down syndrome month. There's this whole community out there for them. There's a day for cerebral palsy patients. For Down syndrome month, people celebrate, but nobody has a walk or a t-shirt for my child's disease. So she feels like all these benefits that she was hoping for from this diagnosis just aren't there, in part because of the rarity of the condition. And the other piece that we weren't expecting as much, but really came out very strongly, was this idea of phenotypic consistency. So if you follow the rare disease space at all, you'll know that the naming conventions in rare disease are all over the place. And what actually constitutes a single disease is not only being disrupted by sequencing, but was already quite variable. Here the parent is talking about the more they learned about the condition that their child was diagnosed with, they felt like, their child wasn't actually that similar to any of these kids, that they actually saw more differences in the child than similarities. This parent went on to say that essentially they felt like they had a new label, but nothing otherwise was different from prior to diagnosis. And then finally, I want to talk a little bit about what happens to our undiagnosed families. And I titled this theme, Not All Pathways to Value Go Through Diagnosis. So following these families over time, what we were really struck by was the ways in which they felt they derived value, they perceived value, regardless of the outcome of the testing. So in some cases, that was because they felt like the process itself had value. This quote on the left is from a mom who says, I feel like this process has been how great the team and the researchers have been, as well as for us and me mentally going through the process. So this feeling that parents described feeling like they were fulfilling their obligations as parents in getting to the point of sequencing. Don't you love it when a participant just gives you a quote that you're like, that's the one I needed you to say. She says, I feel like I lucked into the benefits that I wanted to get from genetics results. And because she happened to meet a mom with overlapping features who introduced her to a surgery that happened to be beneficial for her son, that she felt like he was really going to benefit from. In addition, parents talked about, what by the time they get to this point of sequencing, this idea of not having a label or a name changes, because perhaps while their child was really young and they were really still learning to cope with the complexities of caring for a child with a chronic illness, they didn't feel like they really knew their child as a whole person. But over time, they felt like they got to know them, and they realized they essentially were treating a whole person, not just a syndrome. And further, this person goes on to say, they already have all the specialists they need. That's not going to change. And one of the other pieces that we saw is that healthcare providers can play a really key role. This parent on the right describes how her neurologist added cerebral palsy to her child's diagnosis list because they were notified that speech therapy wasn't going to be covered without that diagnosis. Now, I'm not advocating for Medicaid fraud at all, but I do think this speaks to the incredible role that providers can have in facilitating access to care for patients that doesn't necessarily need to be contingent on understanding the etiology of disease. So you may be thinking that I'm trying to convince you that diagnosis for these patients is not actually important. And I want to be really clear. Parents saw diagnosis as having the potential, at least, to have a range of benefits. And that was really aligned with the literature on existing utility, but it also didn't capture the whole picture. Yes, we saw some instrumental value in diagnosis for access to services or guidance for clinical management. And they really anticipated its intrinsic value of knowing that I mentioned earlier. But in examining how the parents talked about their search for diagnosis, they also expressed this much deeper, almost existential value, in so much as they saw their search for diagnosis as part of what it meant to be a good parent who provided their child with with what they referred to as their best life. And so we're proposing that all of this different instrumental value, and we have another paper that's coming out in the near future on this, that all of this other instrumental value, while important, almost misses the main point, which is that that this value is deeply embedded in what it means to be a parent for these parents, is deeply embedded in what it means to be a good parent for their child. And just to give you some examples, and this is where the term best life comes from. This mom says that if my son has something fatal, we shouldn't be sitting in our house watching effing Mickey Mouse. We should be on a beach in Hawaii, and we should be going to Disneyland, and who cares if he gets COVID, because he should live his best life. This parent really felt like she couldn't parent her child in the way that she needed to, in the way that was best for him, unless she really understood, this was particularly during COVID times, what his level of risk was and how she could maximize his quality of life. Another mom talks about, and this mother actually talks about how it doesn't even need to have instrumental value to speak to this idea of giving their child their best life. I think she summarizes this really perfectly when she says it changes everything and it changes nothing. They were a family that clinically, because of the phenotype, they had all the care they needed, and she was an incredible advocate. They had access to all the services, but the diagnosis did tell her that her child's disease would not be degenerative. And so for the family, just this value of knowing that their child was hopefully going to be with them for a long period of time was incredibly valuable. And also she felt like that allowed her to plan for the future in a way that, again, could maximize her child's quality of life. Let me just stop for a second. I know I just threw a lot at you. And see if there are any questions. And then I'm going to go on to talking a little bit about gene therapy. I'm going to sip some water. Questions? No? Okay. So we talked a lot about sequencing and diagnosis. One of the ways, is there something on? Oh, I didn't see. Yeah, please.
What's the central framework to try to think about, the idea of there's a diversity of or diverse family perception of experience or outcome value of this, how that's anchored in diversity of initial setting of expectations at the beginning of the journey, kind of thing, right? And how that influences long-term perception.
Yeah, that's a really good question. There's actually a really great paper by Sarah Ackerman and colleagues at UCSF that just came out, I believe, in the last 6 months or so, where they looked at, they were working specifically with families from underserved populations who were getting sequencing, and those families agreed to be part of the study, and even though they weren't explicit about it at the time, because they had this idea that if they got a diagnosis, they'd be able to get better school supports for their child, right? And of course, in a consent, you wouldn't necessarily think to very explicitly call that out, right? And say like, oh, and by the way, this probably won't change your child's access to education, except if it happens to be this very niche thing that you get a diagnosis with. What I'm advocating for right now is to really make sure that we ask families what they're hoping to get out of this, because we know that they go into sequencing with a lot of misconceptions, regardless of their socioeconomic status, but in particular, a family that's taking the little resources they have to get to a point where they can get sequencing, when they could perhaps use those resources for other strategies to improve their child's educational status. It feels like a disservice to them if we're not being entirely transparent. And I think there's, for lots of reasons that are understandable, a lot of excitement around what we can do with sequencing and a lot of interest in enrolling, underserved communities. But if we are over-promising in terms of the benefits, we're essentially creating a situation of, it's like the diagnostic misconception equivalent of therapeutic misconception. We're enrolling them in trials or offering them these technologies on knowing or that they are quite likely to have a misconception of potential benefit in terms of what they can do with that information. I don't necessarily think informed consent alone is the answer though, and actually I'm going to talk about that a little bit at the end, but it's a great question. Yeah.
You have a question online from Theodore Wilson. Did you collect information on if patients regretted participating or would not do the same thing over if offered comprehensive testing a second time?
Yes. So, yeah. This one?
So the question from online from Theodore Wilson is, did you collect information on if patients regretted participating or would not do the same thing over if offered comprehensive testing a second time?
Yeah, so not formally, but that did come up in our qualitative interviews because they were very open-ended. And I don't have those data in this slide deck, but we did publish a paper in the Journal of Pediatrics last year that looked at specifically at some of those issues. And we found the short answer is not all families, but certainly some families were very upset. Not that they felt like the sequencing itself had hardened them, but that because of the opportunity cost, they recognize that they could have been putting their resources and efforts elsewhere, as opposed to enrolling in research and the time and effort putting their time and effort in that direction. Cool. Yeah. Oh yeah. Not enough. And that's actually an area that I'm starting to do some work in because, so much of the data in that space is based on these arguments that there's a lot of clinical utility and cost savings. But the way we define clinical utility is widely variable and frankly, highly problematic, including, we're actually doing a systematic review right now because in doing a not so systematic review, we were really troubled by how much of the clinical utility, if you dig into the supplementary tables, is actually the clinical utility and cost savings is coming from transitions to comfort care, which is, to be clear, a very legitimate choice that families can make, but there's no information on whether it had personal utility for those families. And so we're kind of asking the question of what's the utility of clinical utility and whose utility is it? And the other thing that we saw, which is not as frequently, and again, we're not done with the systematic review, but we also saw families who were getting a negative exome, so didn't get an answer, and then choosing comfort care, and which is, I think, almost more concerning to me. And I mean, I don't know if there are any genetic counselors in the room, but the genetic counseling around that feels almost impossible to really communicate that level of uncertainty. One of the other pieces that has come up in our study that I've been thinking about a lot as it relates to NICU is parents saying, I don't think I had that quote in here, but saying I'm glad I didn't get an answer sooner. I wouldn't have been able to handle it earlier, but now I know who my child is and they had built up that relationship. But we have not done long-term studies on that. We haven't. And the little bit of literature that's out there is basically from families who volunteer to talk about their experience. And those are not going to be your happiest, they're going to be your happiest families, right? There is one paper that literally just came out this month that did do some interviews, six-year follow-up from children who received sequencing in the NICU. Both those who did and did not get diagnoses, and it was the same. They all had lots of complex medical needs. They all had a lot of uncertainty they were grappling with. They all cost the system a lot because they were complex chronically ill kids. Yet these data are being used by advocates and by industry to advocate for coverage, Medicaid coverage for sequencing in the NICU in a lot of states. And frankly, I think the conversation about opportunity cost there is not nearly as robust as it needs to be, given all the different things that Medicaid needs to do to take care of sick kids. Is sequencing really the right bang for your buck? Yeah, it's a great question. Anything else?
I'm one of the inpatient genetic counselors.
Oh, yeah.
I like your comments about the parents perceiving genetic testing as like something that they could do. Yes, sorry. Hi.
Hi.
I'll reintroduce myself. My name is Jenna. I'm the inpatient genetic counselor. I was saying that I like the comment about parents perceiving genetic testing as like something that they should do in order to be a good parent in
Mhm.
some ways. And I like thinking about it now, that does seem like kind of like a trend. Like parents are like, well, I want to do anything and everything I can to care for my child, or I want to know everything I possibly could or should for my child, for a baby who's a day old. And like, I'm totally on board and supporting those families, but sometimes we learn some really difficult information. And we have had some conversations about, as a team, reviewing those kids that got a terrible diagnosis and they kind of quickly were redirected to comfort care, and working with like bioethics teams and like the bereavement counselors on like potentially interviewing those families, to see if they felt like having a genetic diagnosis brought them more comfort in choosing that, knowing that, you know, this kid is super sick right now and we have a name for it, and we know that every other kid did really poorly and that there's no point in prolonging the suffering, knowing that the outcome is going to be the same either way. Like, I've had families sign DNRs within 24 hours of getting these news, but that's really heavy for us to be that team delivering that information. I've also been on the other end where we give a really horrible diagnosis, but like the primary team doesn't quite grasp what we're saying.
Mm.
And then they're still offering surgeries and still offering like interventions until someone else comes in and consults ethics. And it's like, should we really even be offering more surgeries, more prolonging of suffering if this is going to be the outcome either way? And so I've kind of seen it happen on both ends of the spectrum. And it's definitely something that's really challenging to navigate, getting this information so soon before, and how to use that information in a way that's helpful for the family's experience and not causing more harm.
Right, right. Thank you for your comments. I really appreciate that. I'd love to talk with you. Yeah, I would love that. I would love that. But what's I gonna say about that? Oh, yeah. So I've just a couple comments, then I want to move on. Oh, I'm never going to get through all my slides, but that's fine. Which is, oh, darn it. I woke up really early California time, so I'm a little bit, I'm starting to lose my train of thought a little bit, but I'll think of it and we'll talk. How about that? So let's talk a little bit about gene therapies, because this is another argument that's made for why we should do all this sequencing, because we can catch these kids early and now we can treat them for many millions of dollars. And you've probably been following the data on this. You know, Lenmeldi for MLD just broke the record again. It's just been one record being broken after the next. You know, these prices are justified based on this argument. The price of the therapies offsets the dollar saved by avoiding caring for this very sick child over time. Particularly if it offers this long-term cure, not only does it save money, but also the child stays alive, which of course is the goal. But they come to this using value assessment, that QALYs per life year saved. But as I was just talking about, this idea that alone is a measure of value doesn't capture the perspectives and the values of necessarily even the families who are receiving the treatment. And so this is a study that I'm just going to go over really quickly, that some of my colleagues and I had a colleague at Harvard, Hadley Stevens-Smith, who actually is also a KO1 recipient, like Colin from NHGRI, and we got a group together to think about how values were informing the value of gene therapy. And so we took this this value flower, which is something that one of the large health economics organizations is promoting, and that when they're saying that, you know, QALYs is on there. Yes, we're thinking about increased length of life and increased quality of life, but value also is and reduction net cost. But there's also all this family spillover, and you know, if it's easier to administer, it's more valuable, and if it's a larger patient population, maybe it's more valuable. It's a more severe disease. If it's a bridge to other therapies, it's more valuable. If it is going to reduce as opposed to exacerbate equity concerns, which is of course related to things like ease of administration, right? And then they're even arguing that these therapies have scientific value in and of themselves. And so they're really pushing for this expanded notion of value. But we were interested in how different stakeholders, how they prioritize these different value elements, what they saw as the most important factors that made one of these therapies valuable. And so we talked to 30 participants and we had them rank those 10 value elements that I just showed you in terms of what they thought was most important in defining the value of these rare disease therapies. We had people from payers, healthcare providers, academic, biotech, government, and from patient organizations. Some of the things we found were very expected, right? So net costs, of course, payers care. Here's a payer saying, Medicaid gets its budget assigned about a year in advance. So once you have a set budget, you have a $1 million product coming to market, and you really have to focus on costs because technically the money could run out. And, scientific spillover, of course, NIH cares. So they say you're opening a scientific door, and there are so many examples of rare diseases opening the door, this idea that rare informs common diseases, that is this idea of scientific spillover is a key component of value. But then we were really interested in looking at how they thought about equity and the role of these gene therapies in exacerbating existing health disparities. We found some people were saying some really interesting things, even though equity kind of fell in the middle in terms of rank order. The people who were ranking it lower were saying things like, things are going to get tossed by the wayside, if we're thinking about because of equity issues, and then everyone loses. And if you can get a treatment first, you should get a treatment first and then worry about equity. So essentially this idea of trickle-down equity. Similarly, this was also a theme in the patient advocacy community. And if you're not familiar with rare disease, the patient advocacy community they are the ones driving many of these therapies. They are at the center of drug development in many cases. They are at the table with the FDA. They are at the table with the scientists. They are at the table with industry professionals. They are really key in driving the process. And here you have one of these, she's a parent of a child who is a leader in one of these advocacy groups who says, eventually we're going to get there. Once all other things are met, we'll get to equity. But saying essentially it's a long time, and if we can't have this conversation too early. And then she says something like, we don't even have the conversation about those who have access that can't get their drugs. So essentially she's saying, like, we need to get people who have access these drugs first, and then we'll figure it all out. And because they have such an important seat at the table, they actually are part of making decisions that have equity implications. So here is this is a father who's part of a patient organization who says, that here he's describing a company actually that they're working with, asking them and encouraging them to consider a different delivery mechanism that is going to be easier to administer and therefore be easier to get access to outside of super specialized academic medical centers. And this father says, I'm going to be honest, we just told him we wanted the best drug possible, and if that was required an ICM, then that's what we should do. And so this actually takes me to kind of my last topic, and what my work is moving towards, and what the R01 Colin mentioned is focused on, is to really think about what the role of patient advocacy groups is, what the role is, what it should be, and how we can help advocacy groups and their stakeholders navigate some really complex ethical challenges that come up in the drug development process. And many of you may have seen, these are just a smattering of the headlines, the patient role in the rare disease space, particularly as gene therapy, the technology for gene therapies and things like antisense oligonucleotides have come on board. This space has just exploded. And with the patients really driving the bus, if you will. And to be clear, this model has a lot of benefits. I think we could probably all agree that, at least in theory and in practice, patients should be at the center of the drug development process, but what does that really mean? And who are the patients who are speaking for the communities in this process? Because we see a lot of variation in patient communities. I don't know if any of you are familiar with the controversy over the gene therapy for achondroplasia. It's not my area of specialty, but there's been some really interesting reporting around the very deep split in the patient community about whether gene therapy is essentially a tool for eugenics or whether it's a treatment for a disease. And you couldn't be quite a bit more wider apart. Kind of in the middle, interestingly, there have been a subset of advocates who have said, gene therapy, fine, yes, sure, but why was the primary outcome height? We have a lot of health issues that we need help with, but height is your problem, not our problem. And so I found that a bit kind of an interesting middle of the road argument. But the point being, who's the patient community there? It's all over the map. Unfortunately, we've also seen cases where certain patient voices are actually being suppressed by their own patient communities. I encourage you to look into this example. So the Duchenne muscular dystrophy gene therapy was received accelerated approval and then expanded approval. And the patient-parent project muscular dystrophy, in particular PPMD, which is one of the large groups, has been really key in moving that forward. They had a patient listening session that was recorded, video recorded, for the community to come and talk to the Sarepta reps who were driving this gene therapy forward and also providing a lot of funding for the foundation. That's part of this landscape as well. And there was a mother who stood up and really was very critical of Sarepta, saying like, why are you pushing this forward? You don't have good data. Yes, we want drugs, but we want drugs that work. And the video was posted online with that section taken out. It didn't take long for people to notice that, of course. And so, of course, it raises these very complicated questions about whether patient advocacy groups, who they're representing, and whether they are really representing the patient community or only a particular slice of the patient community. And certainly going back to that question of access to care, those who are able to have the resources and the time and the energy and the ability to start patient organizations and drive therapies forward come from, as you can imagine, a very specific demographic. And they have a very specific set of priorities. And we really have no way of understanding what the broader patient community wants or prioritizes. It's also concerning because we see advocates at the policy level really pushing FDA. And so in addition to kind of thinking about diversity within a current patient group, there's been a lot of really interesting reporting around the role of patient advocates in pushing for accelerated approval with very little data, similar to the case I just talked about. And the argument is that in pushing those forward without good data, you're essentially prioritizing current patients and potentially sacrificing drugs for future patients, because yes, these patients get access early, but then once you have a drug on the market, there's lower market incentive for development, and the drugs that are there are not going to be available to help current patients. And I really like kind of historical perspectives, and this comes from a sociologist, Rachel Best, who did a really interesting longitudinal ethnography of patient advocacy, not necessarily just in rare disease, but actually prior to the 1990s, health advocacy was really for funding for health research. It wasn't fund my disease. And it was really HIV that changed that. And breast cancer after that. And what this graph is showing you is the increase in the number of disease-specific advocacy organizations, and as well as the increase in disease-specific, in lobbying expenditures by disease nonprofits. And in fact, her data suggests that for every $1,000 spent on lobbying, it comes to $25,000 in expenses directly back to their disease. So it's good investment. However, in aggregate, she found that if you take breast cancer out, which is a big piece, that this movement towards disease-specific advocacy has systematically shifted public funding for research away from diseases that primarily affect women and Black Americans. So there's a systematic equity issue here. But you can also look at individual cases. So if you're not familiar with this paper, it's Farouk and colleagues. It came out a few years ago, but they looked at private and public funding for sickle cell disease versus cystic fibrosis. I don't think I need to explain to this audience that those trend in very specific demographic populations. I'm not sure if you can read the text up here, but although sickle cell disease is about 3 times as common as cystic fibrosis, NIH funding, foundation expenditures were only $102 per patient, compared to almost $8,000 per patient in cystic fibrosis. And those, we know that advocacy dollars bring public dollars. And so you see a similar trend there as well. And so while, yes, we have a new gene therapy for sickle cell disease. That's another complicated example we can talk about. The history is quite concerning. And so just to wrap up, I think one of the questions I get asked and I'm thinking about a lot is, okay, so it's problematic to just enroll underserved patients when they can't actually benefit, but should we then not enroll them? Because that also doesn't seem right. And so this is a paper that we just published in the Hastings Center report that's essentially arguing for thinking about a different way of doing translational genomics research, where we build equity considerations upstream in the pipeline and use kind of principles of justice in thinking about making sure that research is both accessible and beneficial to the specific communities that are being targeted. I don't have time to go into it in detail, but I'll just point you there. And that's going to be something that's going to require investment by all different parties in the drug development genomics landscape. And so we're brainstorming different roles that patient communities, government funding agencies, healthcare providers, et cetera, would need to play to move our research in that direction. We've written a few different papers on this that I'm happy to share, but I want to stop with at least a couple minutes for questions and thank all of my collaborators and funders, and particularly the participants in our research. They're so incredibly forthcoming and willing to share their very painful private moments, and I'm always just incredibly grateful to them. And here's some references. And if you think this was great, please send feedback. If you think it was terrible, I think the link's broken. And I'm happy to take questions.
Well, first of all, just thank you for your presentation. It was really appreciated. And I think that last topic is incredibly important and interesting, but it's also, we're in an incredible dynamic landscape right now, obviously. And so on top of all the structural issues you've been talking about that have been existing in the last, generation, I think that, like you said, the rapid growth, especially in the rare disease space of patient advocacy and those groups have both all the positives and negatives that you were saying, or, effects kind of thing, right? But I think a huge aspect is that if the overall biomedical research funding portfolio, if you will, dramatically shifts even more, that if the public side goes down and then even puts even more pressure to up the patient advocacies, not only will you get the benefits from it, but some of the negatives. And one aspect that wasn't directly addressed here is the influence on research direction. I think that because obviously those organizations have their own missions and values, all of which are legitimate. So I'm not right kind of thing stuff, but its goal is to get to treatment as soon as possible. Everything else, and don't always maybe appreciate the necessary other kinds of avenues of research that may not obviously look like a straight line, but have incredible important implications for understanding disease mechanism and ultimately what are the best therapeutic strategies. So I just think that it's going to be, it's a hard area to do research because the sands are shifting underneath you even as you speak. So thank you.
Yes, they are. And I don't have an answer to that. If I did, I would be president and that would be great. I'm in it for the long haul. I also, I live in the California bubble of politics, and was just saying this morning to Peter, I think that I'm hopeful that the Midwest is going to save us all, because in the Midwest, you have to have dialogue with people with different perspectives. You have to engage in those conversations because they're your neighbors. Where I live, it's everybody, it's very not monogamous. That's not right. It's one perspective. So I don't have answers, but I agree completely. Thanks for raising that.
I have a question regarding the flower of values that you presented earlier. So it seems like we can measure utility for each of these dimensions, but is there any comprehensive utility or a total utility function where you can combine these different value sentiments into one expected utility function?
So that's what this organization wants to do. But what's really interesting is that as they've moved in this direction and said, oh, well, qualities is not enough, it doesn't cover enough. This is actually a model from a couple of years ago. If you look at it now, there's like, I think they're calling it let 1,000 flowers bloom. I mean, they've just got all these different value elements. And what's interesting is what actually ends up in the models is the ones that I won't say we know how to measure, because we're measuring something, but not necessarily even what we think we're measuring with qualities. And most of the other things that people are saying are really important aren't measurable.
And just to follow up on that, if you don't mind, but it does seem like there's something normative here that's not being spoken about, because all values are not equal when we talk about funding healthcare. So somebody says, well, I just like to know, I want to feel like a good parent. So please, I want genetic sequencing. Does that really deserve equal place at the table as evidence that the intervention actually has improved medical outcomes? I mean, I can see both sides. You say, well, they're going to be in pain, and pain is bad. It's emotional pain. But on the other side, you say, well, we do have a limited system, which is out of control, and it means you're not covering something else. Is that, have you thought about that, or these people think about that?
Absolutely, absolutely. And it's a conversation I'm trying to gently have with the advocacy community. I think one of the challenges is that we don't have, I've said this already this morning, but we don't have a shared moral model for how we pay for healthcare. And so, while in Europe, it's not a perfect system either, but arguably they actually have a system of kind of procedural justice to decide what they are going to pay for and what they are not, and what society values. Here, in a lot of cases, advocacy is driving that, and I do think that's problematic, particularly when you're talking about public payers making those decisions. And but I don't think we're going in the right direction there either. I mean, now qualities aren't even allowed, and qualities are problematic, but yes, absolutely, looking at clinical outcomes is.
One more question, but we understand something left to leave for path one.
Oh, sorry.
I have just a quick question. I wonder about your thoughts on this, and you may have already said it and I missed it or something along those lines, but when you were showing the graph that showed the increased price of these drugs, the thing that comes to mind to me is that, industry has its explanation for why that is. That's sort of like, well, it costs a lot to develop these drugs and there aren't a lot of people who need them. And so there's a sort of ROI problem from pharmaceutical companies. But when I look at the expense there, what I see, cynical Jane sees, is that what we're actually learning is that there is no ceiling on what a parent will pay to save their child's life. And the pharmaceutical companies kind of know that. And so each step up is more of a reflection of them testing where that ceiling might be. But then I think that I question myself on that, because, well, there's an insurance thing that hovers in the background as well. So parents aren't necessarily paying all of this entirely out of pocket. And I kind of wonder how you're tangling with that feature.
Yeah, no, I mean, I think you're absolutely right. There's not transparency in general around where these prices are coming from. And there is, gosh, there's an organization now, I think it's actually called ICER. Yes, it's ICER, that's doing independent cost effectiveness analyses around these, that is providing some information. I mean, I'm sure, they have so much money and so many people working for them, they've got to have figured this out. But what is interesting is that we're actually seeing some of these therapies just having very low uptake, even among eligible participants who have insurance, because there seems to be not only the price, but also, like, if there is a therapy that it's kind of the devil you know and the devil you don't know, that we're seeing this in sickle cell too. There's thousands of patients who could potentially benefit from that, but there's really low uptake. One of the companies is about to go bankrupt. And I think in part because, yes, improving health is critically important, but what improvement and what benefit means needs to be patient-centered. And I'm not sure all that work was done as it needed to be from the beginning. Yeah, thank you. Yeah, thank you all.